Another group here we have what we call Paracoccidioidomycosis. This Paracoccidioidomycosis is caused by mostly subspecies of fungal agent called Paracoccidioides brasiliensis. Paracoccidioides brasiliensis. Uh, Basically, it is inception and development. It mimics that of plastomycosis and coccidioidomycosis. And then, of course, the ideological agent now is given there is also geographically restricted in South and Central America. Um, what are the clinical manifestations? From the subclinical infections that are detected only by skin test positivity to chronic unifocal infection, we have quite an array of conditions like number one, pulmonary paracoccidioidomycosis. In most cases, it has an indolent onset and patients present with chronic symptoms such as cough, fever, night sweats, malaise, and weight loss. But when you do some chest x-rays, this can be of help uh, to infer or to give an impression, but it is not a conclusive diagnostic procedure. So for you to be comfortable, the lab must be able to differentiate this paracoccidioidomycosis from the histoplasmosis and tuberculosis. That way, because it's very confusing and have some similar uh, presentation. Number two, this mucocutaneous paracoccidioidomycosis comes in after the pulmonary paracoccidioidomycosis has not healed up. So this again, the mouth and the nose are the most usual mucosal sites that are infected. It seems to be liking along the mucosal wallings. And for this mucocutaneous paracoccidioidomycosis, its study shows that mostly the mouth and nose are easily affected because of the mucosal lining. It causes painful ulcers that develop on the gums, tongue, lips, or palate, and can progress over to weeks or months. It can make some perforations of the palate or nasal septum may occur, and even these lesions can also occur on the face, around the mouth, and the nose. But those who are patients with severe infection, this lesion can spread all over the body. It's a very severe disease that can cause what you call chronic granulomatous disease that normally presents or produces what you call primary pulmonary infection, though with no symptoms, but it can spread very easily to other parts of the body, causing ulcerative granulomata of the bronchial, nasal, and occasionally the gastrointestinal mucosa. From there, it can metamorphosize to number three, what we call mucocutaneous paracoccidioidomycosis, which is start extensively destroying the facial features. Isolated lesions on the pharyngeal mucosa is evident. You know, if it's those ulcers are within the nose or the mouth, become so uh, pronounced. From there, it spread to what we call the lymph nodes, causing lymphonodular paracoccidioidomycosis. So when you have this lymphadenitis, which is common in young patients, Cervical and submandibular chains are the most obvious manifestation, and lymph nodes may progress to form abscesses with draining sinuses. So as it disseminates through blood, it can spread this P. brasiliensis, resulting into what we call the systemic disease, including lesions on the small and large intestines, hepatic lesions on the liver, adrenal glands, osteomyelitis. So it's a disease that spread all over the body up to the brain. Very, very, very dangerous. So just like other agent fungal agents that we've talked about today, these are the common samples that you still, collect: skin scraping, sputum, bronchial washing, etc. Um, then when you want to do culture, it must be uh, appropriately tested and confirmed to be working safety cabinet. Any positive isolation or culture must significantly be taken serious and treatment be given. So that we've looked at a group of dimorphic fungi that all of them, the source of infection is through inhalation of the conidia, and then the difference is the fungal agents, and because they're systemic, once they reach in the lungs, either they are healed through immunocompetent competent person, or it proceeds to establish disease by spreading or disseminating to other parts of the body, as it has been illustrated. Then you look at the sample collected are more or less the same. What matters is what the lab will do the isolation. Then it really, really mimics TB infection. Therefore, we must go a notch higher to uh, do lab tests to separate the two in terms of analysis.